All right, Assalamu alaikum. Good morning, subah khair. Very details आपने देखी. I am a histopathologist at Arakan and for over 35 years now. And the job of the histopathologist, if we talk about diagnostics, is that all tissues which are removed from the human body, they come to us. Whether it's a brain tumor, gastric biopsy for Helicobacter, breast tumor, some bone tumor, kidney, anything which is you can think of, right? So we make very important decisions, and a good chunk includes biopsies from suspected malignancies or tumors or cancers. So that is a very important decision: cancer, no cancer, if cancer, which type of cancer, and so on, right? So naturally, my teaching interest and research interest is also in cancer research or neoplasia, right? So today we will talk about some very basics, right? And tomorrow we'll some more deeper stuff, hardcore stuff, titled carcinogenesis. We'll talk about oncogenes, tumor suppressor genes, and stuff like that, right? Okay. So, neoplasia. So, neoplasia literally means new growth, right? And the new growth is a new plug. And what oncology is, that Greek dynasty followed by Roman Empire. They were on top of the world, for a very long time, and they were scientifically advanced as well, and that's why a lot of terminology in medicine as well is either derived from Greek or Latin, right? So, oncos means tumor, and oncology is the study of tumors or neoplasm, and oncologists obviously are those which treat the patients with tumors or cancers. And remember that cancer is the common term for all the malignant tumors, right? So cancer is the term which is used both by professionals like us and a man on the street, right? Whenever they say cancer, means malignant neoplasm. Neoplasms are either benign or malignant, right? Well, it's not easy to define neoplasia. However, neoplasia is a abnormal growth. All life, including us, we grow from embryo to adult. And our body, an adult body, for instance, have hundreds of trillions of cells, right? However, our growth is highly, highly regulated. And that's why, we have 5 fingers. Fingers usually don't grow beyond a certain size, and so on, right? So this is a highly regulated growth. But if those checks and balances are gone, then growth is haywire, and it doesn't follow any rule. And that's what cancer is, right? So today we'll talk about initially some basic nomenclature, right? Clonality of tumor and epidemiology of cancer, because I also chair Karachi Cancer Registry, and tomorrow we will do the carcinogenesis, right? So today some basic stuff starting from the nomenclature. So remember that all tumors, benign or malignant, have two basic components, right? Tumor cells and its microenvironment, right? Actual tumor cells, right, that constitute the parenchyma, and its microenvironment, which include stroma, connective tissue, vessels like angiogenesis, and new vascularization, and in many cases lots of inflammatory cells, macrophages, which secrete cytokines. It's a complex, and the balance between these two components vary from tumor to tumor. However, if you take out one of these, tumor won't be able to grow. So both are important, right? So for example, this is a case of colon cancer, adenocarcinoma of the large bowel, and you see actual tumor cells, right? These are all tumor cells, and because this is an adenocarcinoma, it is trying to recapitulate normal colon. So you see a gland there trying to form a gland, right? Even you see a normal mitosis, bipolar mitosis there. And in between you see this capillary. This is the endothelial lining of the capillary. You see the red blood cells, right? So this is part of the supporting stroma. Okay? So, neoplasms are either benign or malignant, right? Just to give you an idea, about 70 to 80% neoplasms are benign. Most common is fibroid uterus, leiomyoma or fibroid uterus is the most common benign tumor in females. Right? We'll come to that. And 20 to 30% are malignant, which you call cancer. Okay? Now remember that great majority of neoplasm, they are derived from epithelium. And the tumors which originate from the epithelium are called carcinomas. So never confuse carcinoma and cancer. Carcinoma is a major type of cancer which originates from epithelium. And obviously if it arises from skin, it may be squamous cell carcinoma, depending on the lining, or basal cell carcinoma, or if it is from the colon, adenocarcinoma, if it is from the bladder, urothelial carcinoma, but carcinomas. Because you see that if you see the data of any cancer registry around the world, you will see that top 10 cancers that kill the humanity are mostly carcinomas. Like bronchogenic carcinoma, which you also call lung cancer, right? Breast carcinoma, most common cancer in females. Prostate carcinoma, most common cancer worldwide in males, not in Pakistan but worldwide. Colonic carcinoma, oral carcinoma, oral cancer, most common in Sindh, including Karachi, right, in males, and second most common in females after breast, right? So, malignant tumors of epithelial origin, but no matter they are derived from the ectoderm or mesoderm or endoderm. You know that there are 3 germ layers, and epithelium may originate from all 3. So no matter they arise from ecto, endo or meso, you still call them carcinoma. Thus, cancer arising in the epidermis of ectodermal origin, means the skin, as is a cancer arising in the mesodermally derived cells of the renal tubules, like renal cell carcinoma, kidney tumor, and the endodermally derived lining of the gastrointestinal tract, like gastric carcinoma, colonic carcinoma, right? Now coming to second important group, mesenchymal tumors. First, benign mesenchymal tumors. What is mesenchyme? All, fibroblast, bone, cartilage, right? Fat, you name it, muscle, all these things are mesenchyme, right? So, mesenchymal tumors. Now, in general, these are designated by attaching the suffix "oma" to the cell of origin, right? Like a benign tumor arising from fibroblastic cells is called a fibroma. Huh? Okay. A chondroid tumor is called a chondroma. A osteoid tumor is called a osteoma. Huh? A smooth muscle tumor, like we said, fibroid, is called a leiomyoma, right? And you may go on, lipoma, rhabdomyoma, and so on. Now coming to malignant mesenchymal tumors. Now here, you remove the word "oma" from sarcoma, right? So, simple. So, malignant tumors arising in mesenchymal tissue are usually called sarcoma. And they originate from the Greek word "sar." Sar means fleshy. Fleshy means it has more meat and less connective tissue, right? So, fibroma versus fibrosarcoma, chondroma versus chondrosarcoma, osteoma versus osteosarcoma, leiomyoma versus leiomyosarcoma, right? So what do we mean by fleshy? For instance, आपने मेरी दावत की भी है वीकेंड पे और बिरयानी आपने बनाने का प्लान किया है, so you will go to the meat shop and will say कि ये रान का गोश्त है, why? Because it has more meat, it has more parenchyma and less connective tissue. ठीक है ना? वही अगर आप रिब्स पे चले जाए तो उसमें बोन कार्टिलेज ज्यादा होगा और मीट कम होगा. Carcinomas are like ribs. इसीलिए फॉर एग्जाम्पल अगर किसी को ब्रेस्ट लम्प है, the experienced surgeon just by mere palpating may suspect if it is a benign fibroadenoma or a breast cancer, because carcinomas has a lot of connective tissue, so they are hard on the patient, right? So carcinomas have more connective tissue, less parenchyma. Sarcomas have more parenchyma, less connective tissue, right? So this is one of our cases. Sarcomas are mostly spindle cell in, they are spindly. The tumor cells are elongated, right? You may have a small round cell tumors in children, but mostly sarcomas are spindly, like this. This is a leiomyosarcoma. This is the malignant smooth muscle tumor, right? And you see all these tumor cells, you see a lot of mitosis. These are all mitosis, right? So, let's sum up carcinoma versus sarcoma. Origin, carcinomas from epithelium, sarcomas from connective tissues. Behavior, both are malignant. Frequency, carcinomas are much more common than sarcomas. Preferred route of spread or metastasis, carcinomas like to spread initially to the regional lymph nodes. And therefore, as soon as a breast cancer is diagnosed, the first place you look for a spread or metastasis are the axillary lymph nodes, because breast drains there, right? However, eventually, lymphatics, they also drain into blood vessels. So eventually you may get metastasis to various organs like bone, liver, brain, anyway. However, sarcomas, they rarely go to lymph nodes. And they directly, most common place of spread of sarcomas is to the lungs. So the first place, for example, a child having bone tumor, osteosarcoma around his knee, the first place you will look for a spread is the lung, right? And not the lymph nodes. In situ phase, this is a phase in which the abnormality is above the basement membrane, because epithelium lies on the basement membrane. And this is only seen in epithelial tumors. I will come to that in detail. In situ phase is only seen in epithelial malignancies and not in mesenchymal malignancies. Age group, carcinomas mostly adults and elderly, like prostate cancer, breast cancer, colon cancer, gastric cancer, right? And sarcomas in children, the malignancies pattern is very different. The most common malignancies in children are hematolymphoid, like leukemias, which, a layman called, say, blood cancer, leukemias, lymphomas, brain tumors, and then bone and soft tissue tumors, right? But in adults, mainly carcinomas. So here, again, compare the nomenclature that the tissue of origin, squamous cell papilloma versus squamous cell carcinoma, bone adenoma versus adenocarcinoma, leiomyoma versus leiomyosarcoma, right? So lipoma versus liposarcoma, osteoma versus osteosarcoma. So that's how the terminology goes, right? All right. Now, one concept is very important in neoplasm, both benign and malignant, that they are monoclonal, right? Monoclonal means that they are the progeny of that one cell which had acquired all the right mutations and is able to divide. Right? I mean, we, for instance, are biclonal. Most life is biclonal. 50% of our genes comes from father, 50% from the mother. Though technology is available to produce monoclonal mammals and I will come to that. But natural life is micro. But tumors are by definition mono. So, what do you think? If you start from one cell, which is now full-fledged cancerous cell and is able to divide, you know, the smallest clinically detectable tumor is usually 1 centimeter in size. And if we take the average size of the tumor cells, a 1 centimeter tumor should have something like 10 to the 9, means a billion cells. Billion means 1,000 million or 100 crore या 1 arab cells. What do you think? That one cell has to divide how many times to produce a billion cell from one cell? Let's see your mathematics. See?
1 power 9.
Huh?
1 power 9.
क्या कहा इन्होंने? क्या कहा?
2 raised power 9 1.
10 to the 9 तो सेल बनने हैं ना. आपके पास 1 रुपया है.
35 days sir.
1 रुपया है और उसको बनाना है आपने 1 अरब.
2n square की फॉर्मूला
हाँ?
2n square का फॉर्मूला
Only 30 times. This is the exponential growth. That's how the money grows. That's how the population grows. That's how in no time, bacteria, viruses, they become billions and trillions. Right? When you haven't watched our कौन बनेगा करोड़पति कभी नहीं देखा है? बच्चन साहब का है शुरू में 2000 है 2000 है फिर all of a sudden it becomes 1 crore 2 crore 5 crore 10 crore है? आप लोगों ने कभी PCR मशीन यूज की है? To make a billion copies from a one copy, you set your machine on 30 cycles. 40 cycles पे रखेंगे तो वो तो क्या कहना चाहिए 10 to the 12 हो जाएगा. 1000 बिलियन हो जाएंगे. एलन मस्क के बराबर हो जाएगा. समझ गए ना? 1000 ट्रिलियन. क्या नाम है? 1000 बिलियन इज अ ट्रिलियन. इसीलिए देखिए planet Earth पे only 150 years ago we were 150 billion. जो planet Earth की जो population थी, now we are about 9 billion. इसीलिए the rich gets richer, because it's exponential. आप देखें ना एलन मस्क की कुछ चंद महीने पहले उसकी वर्थ थी 500 बिलियन और half trillion. Within few months, single doubling हुई ना, वो 1000 बिलियन हो गए. और this is from the Robbins textbook of pathology, basic thing. Right? Normal cell is cell which has acquired all the right mutations, right? Only 30 doublings. A billion cells. 10 more doublings, trillion cells. But usually this is not compatible with life and the patient dies before that, right? Okay? ये क्या है? Dolly death. So this is the picture which was taken by me when I visited a few years ago to Edinburgh to take an exam and visited its museum, which is next to the fort, very famous museum, and have a section of science as well. So because it was the first mammal which was cloned, in University of Edinburgh. So after her death, they preserved her, and now if you ever visit, you will see Dolly there, right? So this was a defining moment in science, right? And this is written, I have taken this picture, and because of the light, it will be difficult to read, but it says that Dolly's birth showed that cells can be reprogrammed to function as different type of cells, right? This was an important step for stem cell research, which can be used for new stem cell therapies. For instance, creating organs for transplant that your body won't reject. This could be achieved by cloning your cells to produce an embryo and then taking stem cells from this. With all these embryonic stem cells, they can then be treated to develop into the required cell types such as brain cells. There are non-committal stem cells, common sources, umbilical cord and all those, which can differentiate into anything under the sun. And then, like you and me, we have the organ-specific stem cells. Because all the time, new cells are, old cells are born, pattern of life everywhere. And even universe, born, mature, and die. And they are replaced by stem cells which are present in the basal layers. They replace those cells. This is continuously happening, right? In bone marrow, it is extreme because the life of the red blood cells, white blood cells is very short. In liver, it may be a little slow, but it's happening all the time, right? So, it changed the myths in several ways, because before this, it was thought that life is only possible from the germ cells, which are present in males in testes and in females in ovaries. But Dolly was not from the germ cells. They have taken the somatic cell from the breast duct, right? So it means that it is possible to reprogram a mature cell and to deprogram and then reprogram, right? Even a somatic cell, right? So, the stem cell, obviously, research is something it has no limits. Its potential is so much that it's unbelievable. Even humans may be cloned, and what has stopped the scientists is not that science is not there, is that scientists themselves, they decided that this is the red line and we will not cross that, right? Okay. All right. Now coming to cancer registries or epidemiology of cancer. When I chair Karachi Cancer Registry, Hyderabad Cancer Registry, and I am co-chair of the National Cancer Registry. In true sense of the word, in Pakistan there is no National Cancer Registry. And after a lot of effort several years ago, we motivated all functional registries, cancer registries like Karachi Cancer Registry, Shaukat Khanam, so-called Punjab Cancer Registry, Pakistan Atomic Energy Commission Cancer Registry, Armed Forces Cancer Registry, to share their data, which we may combine and analyze, right? So this was the first ever paper which was published, right? So you see, more cancers in females than males. Why? Because breast cancer in Pakistan is so common, right? That it surpassed, so more cancers in females because breast cancer is so high in Pakistan. And I will show you the patterns. Top 10 cancers in males. In males, the most common cancer in Pakistan is the oral cancer. And that is particularly, this place, Pakistan, where gutka, chalia, all those things are, rampant. And mind you that this is a preventable cancer. In our archive, 80% of the oral cancer patients were chewers or smokers, mainly chewers, right? This is not the case if you take the whole planet. It will be prostate cancer, right? But in Pakistan, because what happened that 20 years ago, 25 years ago, the most common cancer in males in Karachi used to be the lung cancer due to smoking and all. The smoking is still there, but because while pulmonologists were busy in anti-smoking campaign rather than anti-tobacco campaign, masses slowly moved to smokeless tobacco, right? Because still you may do air travel and take out the sachet from your packet and chew tobacco and gutka or whatever, huh? But you can't smoke. So slowly they moved to this, right? So now lung cancer, you see, is on number 4, right? Liver cancer is number 2. Again, because about 8 to 10% of Pakistani population is a carrier of hepatitis B or C, right? Then colorectal cancer, large bowel cancer. About 20 years ago, it used to be in top 10. Now it is in all cancer registries in Pakistan, it is in top 5. It tells you our westernized lifestyle, more fast food and things like that. Lung cancer, obviously it has a very strong association with smoking, but I think 2-3 days ago I was watching BBC or Al Jazeera, and they were saying that in India, in Delhi obviously, in India and Delhi, 50% of the lung cancer patients never smoked. And they thought it is because of the pollution. Because Delhi or Lahore, usually, or Karachi, when they are the most polluted cities in the world. And I'm sure that those who have their business in Empress Market or Sadar or Bandar Road, their overall life expectancy must be 10 years less than the controlled population, right? Even those poor guys on motorbikes outside the university hospital, even within the university, so much dust and all that, all, causes your lung damage. And so, breast. In females, you see, about 40% of all cancers are breast. Right? Then ovary, then oral cavity. This is national data, right? in Karachi cancer registry, breast is followed by oral cancer. Right?
सर इसका रीजन क्या है?
ये तो एक अलग सवाल है.
क्योंकि ये तो पॉल्यूशन का इससे कोई ताल्लुक नहीं है.
नहीं, ब्रेस्ट कैंसर का तो पॉल्यूशन से ताल्लुक नहीं है. इसका many reasons. I think genetics should be a major reason because cousin marriages are hooping about 70% in our rural areas in particular. So if there is a bad gene like BRCA mutated gene, it will have no chance to. It will remain in the family. Same happened in Jews. Because Jews, they don't marry outside their community. So again, Ashkenazi Jews. Ashkenazi Jews means European origin Jews, like Einstein was an Ashkenazi Jew. They also have a very high incidence of genetic disorders and, breast cancer and all kinds of genetic related cancers. So that may be one reason, right? Certainly, because we don't know when there is no genetic testing, and cousin marriages, we know that increases the chances of genetic disorders many folds, and therefore in many countries they don't allow. Even in US, if there are very few states left which allow the cousin marriages, otherwise they don't allow. Right? Now in children, environment has very little role to play. And it's mainly the inherited mutations which lead to cancer. And therefore in children, the cancer pattern is more or less same around the world. That most common cancer in children are leukemias, particularly lymphoblastic leukemia. Fortunately, if treated optimally, 95% cure, right? Brain tumor like medulloblastoma, lymphomas, bone tumors like osteosarcoma, and all blastomas like retinoblastoma, neuroblastoma, hepatoblastoma, all these occur in children, right? Now this is our city, concrete jungle, and when I oversee Chair Karachi Cancer Registry for over 10 years, but I've been involved in that for 30 years at least. And you see, I won't go into the detail, but more or less same. In males, this is a female. In female, you see breast cancer going through the roof, and in males, oral cancer going through the roof. Right? These are some of our patients. You see that this guy, cancer, oral cancer arising from the cheek, and it is so aggressive that it has penetrated full thickness and is ulcerating outside. Right? Now this woman have a oral cancer on the tongue. And you look, the most horrified surgery, which they undergo in oral cancer, whole jaw is chopped off, whole tongue is chopped off, but still, and 80 to 90% it is a preventable cancer, right? But you know that there is hardly any attempt to address that, right? So why you think this neck is so bulky? थायराइड तो यहाँ नहीं होता, थायराइड सामने होता है? और हम तो कैंसर को डिस्कस कर रहे हैं। These are the enlarged lymph nodes because oral cancer, oral cavity drains into cervical lymph node. आपका गला में खराब होता है तो lymph node ये वाली enlarge हो जाती है ना, oral. So these are all metastasis because patient present at what you call last stage or stage 4. Already when it is spread extensively and prognosis is bad. Right? All right. Now coming to some basic terminology in cancer reporting. If ever you read a biopsy report from a pathologist, few words will come time and again. The tumor cells showed loss of polarity with marked hyperchromasia and pneumorphism and abnormal mitosis, things like that. So what is the pathophysiology of it, right? Now this is a highly undifferentiated malignant tumor which is stained with hematoxylin and eosin, HNE. HNE technique was invented about 150 years. And even today, a biopsy, a tissue taken from the humans, promptly fixed in 10% buffered formalin, rightly processed, nicely cut, and stained with HNE is good enough to make a conclusive diagnosis in about 2/3 of the cancer cases. You don't need, immunohistochemistry or molecular testing and all that in about 2/3 of the cases. So this is HNE. Hematoxylin stains the nuclei, right? And eosin means, pink loving, stains the cytoplasm. Now here you see that some cells are darker than others, right? This is hyperchromasia. Why this happens? It means that these nuclei containing the more DNA content, more genetic material. The reason is that all the time our cells are dividing. But before a cell divides, it doubles its DNA. And then 50% of the genetic material goes into one cell, 50% into the another cell. That is normal. That is called diploid DNA content. However, cancer follows no rules, right? So it may happen that 70% of the tumor genetic material goes into one cell and 30% into the other cell. So one which has a lion's share, that 70% instead of 50%, right, will stain darkly on hematoxylin. So that is what happens. That is called aneuploidy, abnormal DNA content. And for the same reason, the size of the tumor cells is pleomorphism, means variation in size and shape. And this is for the same reason, that they are dividing unevenly, right? Third, you see a mitosis here. It has 4 poles. Quadripolar mitosis. Normally, the mitosis in telomere phase will be bipolar, right? If you see any mitosis which is unipolar, tripolar, quadripolar, pentapolar, that is abnormal. And remember that abnormal mitosis is a feature of malignancy. Even benign tumors will never show abnormal mitosis. Right? So this is the pathophysiology of hyperchromasia, pleomorphism, and abnormal mitosis. For example, this is one of our case. You see, markedly hyperchromatic and pleomorphic nuclei. You see lots of abnormal mitosis. You know, on this H&E, I can tell you this is a highly aggressive malignant tumor. But it's so poorly differentiated that until I do further immunohistochemical workup like immunohistochemistry, cannot predict, if this is a poorly differentiated carcinoma or a poorly differentiated sarcoma or a poorly differentiated melanoma or whatever, right? All right. Now, we said that carcinomas always have an in situ phase. Means that initially the abnormalities are above the basement membrane because the epithelial cells always reside on the basement membrane. And that is only true for epithelium, right? Now, this is the classical example that this blue thing is the basement membrane of the bronchial epithelium, right, in lung. Now, normally bronchial epithelium is columnar ciliated. Remember that great majority of the lung cancers, they don't arise from the alveoli, they arise from the bronchial epithelium. And therefore, the better terminology you will find is bronchogenic carcinoma. But because bronchi are within lung parenchyma, they invariably involve the lung parenchyma, so you also generally you call lung cancer, right? So, just take an example. This is the bronchial epithelium, right? This is the columnar ciliated epithelium. And also assume that this is the biopsy from a smoker. The first thing, the adaptive response which will happen will be hyperplasia. Hyperplasia is a physiological response that is increased number of cells. And beneath that there are also mucus glands. They also show hypertrophy and hyperplasia. That's why, smokers cough. When they get up early in the morning, a lot of productive cough is because a lot of mucus is produced. Right? If smoking continues, what is missing here? Any idea? Is metaplasia. Metaplasia means replacement of one mature type of cell by another mature type of cells. So what happens that columnar epithelium is replaced by squamous epithelium. Why? Because squamous epithelium is multi-layered, more robust, and may withstand the local hostile circumstances in a better way than columnar epithelium. Right? Smoking continues. Dysplasia, right? This means bad, plasia means growth, dysplasia means bad growth. So what happens that various mutations, in this case due to smoking, start to appear in various cells. And they gradually increase. So therefore we differentiate the dysplasia into low-grade dysplasia if it involves the lower one-third, and high-grade dysplasia if it involves at least 2/3 of the epithelium or full thickness of the epithelium. Right? Now the differences between dysplasia and neoplasia. Dysplasia is reversible. If the person stops smoking, this may regress. Neoplasia is irreversible. Right? Dysplasia is polyclonal. Polyclonal means that multiple cells are abnormal. Some have one mutation, some have two mutations, some have three mutations, but none have all the mutations required to behave as an independent neoplastic cell. Right? Eventually what happens, that out of these hundreds and thousands of cells, one cell will acquire all the mutations, will be able to enter into the cell cycle and divide. Right? So this is a polyclonal population, but here it is a monoclonal population, the cells which are produced by the division of that one cell. In severe dysplasia, the abnormality, I will show you the pictures. We say features are consistent with high grade or severe dysplasia / carcinoma in situ. Because on morphology we cannot differentiate. Both will look the same until you do the clonal studies. But doesn't matter. As far as tumor is above the basement membrane, it cannot spread. Right? Because the blood vessels and lymphatics are below the basement membrane. And at this stage, they get their oxygen and nutrition through diffusion. So until they breach the basement membrane, they cannot get access to the vessels and they cannot spread. So until this stage, if you resect this area, patient is cured. However, in lung, this is not possible. Obviously, you cannot. Patient is asymptomatic at this stage. You will not go on doing the bronchoscopy and take biopsies. However, there is another organ in which exactly the same sequence of events happen, which is accessible to us, and that must have led to a saving of hundreds of millions of lives to date. And that is cervical cancer in female. Right? Because of pap smear. Right? The screening program. This is just to tell you, this is columnar epithelium, you see. And here it is replaced to the squamous epithelium. This is just, metaplasia. 100% of the cervical cancers, they arise from the squamocolumnar junction. Right? This is ectocervix lined by squamous epithelium, and this is endocervix lined by columnar epithelium. Again, first thing which happens, columnar epithelium is replaced by squamous epithelium, which we call metaplasia. Then mild dysplasia, moderate dysplasia, severe dysplasia, carcinoma in situ. So the whole idea of pap smear or cervical smear is to take through spatula cells from this area, make a smear, stain and look for abnormal cells. The idea is to, in a population screening program, in Pakistan there is no population screening program, is to detect abnormal cell before they invade the basement membrane. Because once you say that high-grade dysplasia, next day gynecologist will do colposcopy, and with the acetic acid that abnormal area will be highlighted, so they remove that area and patient is cured. Right? So that was the first ever screening program which was uh, invented by a pathologist called Papinacula. That's why we call Pap smear. Papinacula was a cytopathologist, right? And even today, all developed countries, they have Pap screening program. All women, in their reproductive age, they undergo, Pap smear routinely. Usually it's once in 3 years, but if there is an abnormality, maybe after 1 year, 6 months, or so on, still, population-based screening. Now, because cervical cancer have a 100% association with high-risk human papillomavirus, and now we have a vaccine against high-risk human papillomavirus, which is given routinely to all girls at the age of 11 to 14, that may happen after many decades, that there may be no need of such screening, because you are, have a immunity against high-risk HPV, and this association is 100% HPV 16 and 18, right? Okay. So this is one of our case, and you see that full thickness of the epithelium is abnormal, but basement membrane is still intact. This I will report as severe dysplasia or high-grade dysplasia / carcinoma in situ. I cannot tell the difference. Whole thickness is abnormal. But good thing is there is no invasion. Right? So if you remove this area, patient is cured. The same thing happens in mammogram. In mammogram, you look for ductal carcinoma in situ in breast. Right? Because at that stage, there are certain, I'll come to that if some abnormal signals, when they remove that area at a very early stage before it can invade, right? Here you see, it has breached the basement membrane, and now this is invasive squamous cell carcinoma, right? All right, on a lighter note, we will show you some examples, real life examples. This is a uterus which is cut open. There is no cervix here. You see the fallopian tubes. Yellow things are ovaries. And you see this is an endometrial polyp. Mostly endometrial polyps are benign. They are just hyperplasia of the endometrial mucosa. But because must be very symptomatic, patient must be having excessive bleeding, pain, etc. So uterus is removed. But you also see some protrusions inside the endometrial cavity, right? This is actually a fibroid or leiomyoma, right? These are so common that if a 40-year-old, say, woman gets an ultrasound for whatever reason of the pelvis, it is highly likely that the ultrasonographer will report 1 or 2 small fibroids in the uterus. But fortunately, great majority are within the muscle or outside of the uterus, so they are not symptomatic, right? So it doesn't matter, right? Incidental finding. However, if they are just beneath the endometrial lining and protruding into the endometrial cavity, even without that polyp, they will lead to symptoms like excessive bleeding, painful bleeding, infertility, and things like that. Then probably in reproductive age you have to remove that. Right? Now another question, if there is an incidental finding, will be asked by the patient that, this is an incidental finding, I have no symptoms. So shall I go to get it removed? And what are the chances that it will transform into leiomyosarcoma or malignant? The good thing is that in this case, it is exceptionally rare for leiomyoma to transform into leiomyosarcoma. Leiomyosarcomas are uncommon, and if they happen, they begin as leiomyosarcoma to begin with. Leiomyomas of fibroid transforming into leiomyosarcoma is very rare. Right? So no need to do anything. Right? All these are fibroids. This is again one of our case. All these are. You see how symptomatic will be the patient. Endometrial cavity is completely uprooted. This is a mammogram. So another screening program which must have saved millions, tens of millions of lives to date. And you see that this is nipple, breast skin. These are normal breast markings. And here there is an area where breast markings are lost. So this is an abnormal area. So the interventional radiologists, they remove this area. This is called needle localization and submit to pathologists. Most turn out to be hyperplasia, or, but some do show ductal carcinoma in situ. So if that area is removed, patient is cured. Another thing which radiologists look for in mammogram is like an ultrasound thing, right? Is calcifications. Calcifications are more likely to be associated with early malignancy, right? So in developed countries, I think all women starting from the age of 50 years, it is cost is borne by the state, country. They have to undergo mammogram, right? And if there is a family history, maybe earlier, right? Like Pap smear, this is also population-based screening, right? Because breast cancer is so common, much more common than cervical cancer, right? Look, abnormal areas in radiology. So as soon as we diagnose carcinoma breast, for example, the most common surgery which is done is modified radical mastectomy. In that, whole breast is removed along with the axillary tail, which contains the lymph nodes, right? Nowadays, in young women, conservative surgeries are becoming more common, where only tumor is removed with good safe margin, and lymph nodes are sampled separately, right? Or after mastectomy, there are numerous artificial alternatives available. The lymph nodes are removed not as a part of treatment, but as a part of staging to look how far the cancer has gone. Because lymph node positive or negative make a hell of a difference between life and death and patients' prognosis. So this is the breast tumor. You see, this is all fat. And this is ink. We ink that so that we can measure the distance between the tumor and the margin, right? Okay? All right. Now this is a very old, we still have that specimen in our museum. This is the rectum, last part of the large bowel, and this is anal skin, right? And this is a tumor which is black. So which tumor is black? Melanoma, malignant melanoma, right? Which, these melanocytic cells they are present in our, actually this is arising from the anal skin but going into the rectum, right? When, for example, all of us have these black moles. These are benign melanocytic tumors. But if they become malignant, we call it malignant melanoma. I'll come to that, I think, in next lecture. But, countries like Australia and New Zealand, where there's a lot of sun, but people are white Europeans, they have a very high incidence of skin cancer, particularly squamous cell carcinoma, basal cell carcinoma, and malignant melanoma. So this is another category of malignant tumors, right? We talked about carcinomas, we talked about sarcomas, melanoma, and then germ cell tumors, right? Germ cell tumors, they originate in testes in males and ovaries in females. And this is a whole separate group of malignancies. They arise right at the prime of life, at the age of 25, 30, 35, 40, right? This is normal testes and this is a tumor. But good thing is that now with current chemotherapy, they are curable, right? I mean, this Lance Armstrong, all-time champion of Tour de France, cycling on Alps, 8-time consecutive. He discovered at the prime of his career that he has a malignancy which has metastasized already all over the place, including brain. His name is Lance Armstrong, American. And doctors gave him few months, But that was precisely the time, in clinical trials, some very effective chemotherapeutic agents were under trial. And now, even if germ cell tumors are metastasized, in good centers, cure rate is 95%. So cancer is not one disease. So if somebody asks you, Dr. Saab, ye cancer ka treatment kab aa raha hai, that's a very naive question actually. There are several hundred types of cancers, and each one with a different solution. Some cancers are curable today, right? So there can't be one solution for all cancers, right? So Lance Armstrong conquers cancer, got only 95% of men with testicular cancer are eventually cured. Right? This is ovarian carcinoma. This is again a silent killer, no known risk factors. You see, this is uterus, this is fallopian tube, and they usually appear in the form of cyst, right? This is papillary serous carcinoma of the ovary. Then another broader group is lymphomas, right, which arises from the name as says lymphoid tissue. A pathologist, English pathologist, Hodgkin, Sir Thomas Hodgkin, way back well over 100 years, described 5 cases of a malignancy which showed these binucleated cells with prominent nuclei, right? After his death, through another pathologist called Reed and Sternberg, they called it Reed-Sternberg cells. We still call it Reed-Sternberg cells, and this is called Hodgkin's lymphoma, right? To give you an idea, currently only 5 cases. Now the WHO book of classification only of lymphomas is that thick. So many entities. Hodgkin's lymphoma constitute about 30% of all lymphomas. 70% lymphomas are non-Hodgkin lymphomas. So his name is both in Hodgkin and non-Hodgkin. And in non-Hodgkin lymphomas, like here, 80% lymphomas are originated from the B cells. So they are called B cell non-Hodgkin lymphoma. And about 10-20% from the T cells, right? So I think at this stage, Hodgkin's lymphoma and non-Hodgkin's lymphoma and non-Hodgkin's lymphoma are divided into B cell lymphomas, and then B cell lymphoma have 100 other types maybe, and T cell lymphomas, right? Now we are coming closely towards the end. Routes of metastasis through blood, right? Lymphatics, transtheromic. Some cancers, they may directly spread, like ovarian cancer. It is spread and involves the peritoneum, right? And implantation. In a if somebody is suspecting a testicular enlargement and thinking that this may be a tumor, it is contraindicated to put a needle or fine needle aspiration for diagnosis, because if you put a needle, you will breach the capsule, which is called tunica, and tumor will further spread, right? But this is a unique example. Otherwise, fine needle aspiration is common in any case, any tumor. So invasion and metastasis. It is these two properties that account most of the serious and lethal consequences of neoplasm. Invasion is a property of malignant neoplasm inherent in the neoplastic cells. So what the tumor cells, they try to spread locally. They secrete certain proteolytic enzymes to digest protein, connective tissue around tumor cells. But to counter that, our connective tissue or host cells, they secrete some anti-proteolytic enzymes. So whoever takes the precedence, will succeed. That's why cancer is so unpredictable. Some will be locally invasive, some will not be locally invasive, right? So enzymes such as collagenases are of importance, produced by cancer cells, as well as tissue inhibitors, which are produced by our own cells, right? Normal cells. So indeed, it is the balance of these opposing activities that is critical to the invasive phenotype. ये देखिए, ये कुछ वो मेरी एटलस है, उसके ये वेसल्स के अंदर इन्वेजन हो रही है. ये नर्व्स हैं. ये नर्व, देयर आर सर्टेन कैंसर्स व्हिच हैव एफिनिटी फॉर नर्व्स, लाइक प्रोस्टेट कैंसर. ये प्रोस्टेट कैंसर है. अब आ गया मेटास्टेसिस. Again, Greek word change of state is the spread of cancer from its primary site to other places in the body, like liver and lung, with no connection between. Right? And remember, not all cancers they metastasize. And again, it is determined at this cellular level. Only hemodynamics does not explain that because this has access to the lymphatics, so it will metastasize. It is determined at the subcellular level, right? That's why cancer is so complex. You match everything into women with breast cancer. One may be cured, other may be very aggressive and die quickly, So for example, this is the lymph node, axillary lymph node, and this is all metastasis from the breast cancer, right? This is normal liver. This is metastatic adenocarcinoma from large bowel. This is lung. You see alveoli? And this is metastatic osteosarcoma. So, you see, this is from the Robbins. And, it's very complex. that which cells eventually may be able, cancer cells, to have access to the lymphatics and blood vessels, and they are able to survive and then home. Because, certain tumors have the affinity to metastasize to a certain place. For example, bone metastasis. If an elderly male comes with a backache and biopsy shows a metastatic carcinoma, the first thing which we will think, is it coming from prostate? Prostate goes to the bone. If not, maybe from lung, maybe from kidney. If it is female, the first thing we will think of breast cancer, right? So, if I take a cancer cells from the culture medium and inject in your blood, do you think you will develop metastasis? No, it's not that simple. It is determined at the subcellular level, genetic level. So for example, bone is the favorite site. So spread of tumor is not random, and depends on factors relating to both seed and soil, right? Now, finally, two things, very important. Grading of a tumor. Grading is exclusively done by the pathologist. And here we see that how closely the tumor mimic to the tissue of origin. If it closely mimic, we call it well differentiated. If it hardly mimic, we say poorly differentiated. In between, we call it moderately differentiated. You will also call them grade 1 well differentiated, grade 2 moderately differentiated, grade 3 poorly differentiated. So here, you see that it is forming tubules, right? So well differentiated. Here you see that only cords and nests may be in gland there, so poorly differentiated. In between will be moderately differentiated. So this is an independent prognostic factor. Well differentiated tumors behave, their behavior is good compared to poorly differentiated tumors, right? And then finally, the most important thing in all cancer is the staging of cancer. All cancer staging use this system called TNM system, in which three things are taken into account: tumor size, lymph node status, and distant metastasis. There are minor differences in the TNM staging of different cancers like breast versus colon versus stomach and so on, but ideas are same. This is the breast, right? In breast, if a tumor of the breast is up to 2 centimeter in size, we call it T1, 2 to 5 centimeter T2, more than 5 centimeter T3, and if it is ulcerating through the skin, T4. Very important, because T1 tumors, 10% chance to spread. T3 tumors, 70% chance to spread. Right? Then, lymph node. If no lymph node are involved, N node. Up to 3 lymph nodes, we are talking about breast. N1. More than 3 lymph nodes, N2. Then, metastasis, no metastasis, M0. A single metastasis in a single organ, M1. Multiple metastasis in multiple organ, M2. So, if you go to any cancer meeting or tumor board and our trainee is presenting a case for discussion, a 50-year woman diagnosed to have breast cancer grade 2, moderately differentiated, with a stage of T2, N1, M0. And everybody in the room will understand that this is a tumor which is between 2 to 5 centimeter in size. Up to 3 lymph nodes are involved and no distant metastasis. So everything depends on that, and then one can assess the long disease-free survival, long-time survival, treatment decisions, and so on. So this is very important from examination point of view, differences between benign and malignant tumors, right? Growth rate, mitotic activity. This is grade, good, and this is variable. Nuclear morphology, right? Invasion, metastasis, border. This is a kind of capsule. Benign tumors have a capsule. Necrosis, because malignant tumors, they grow so rapidly that they outpace the blood supply, so they become necrotic in the middle. Ulceration, common in malignant. And direction of growth, the cancer is like a rodent growing inside rather than outside. So with that, we finish this first lecture. And if there are any questions, please. I'm sure they will have lots of questions.
سر آپ نے کہا کہ ایک ڈیٹیکٹیبل ٹیومر سائز جو ہوتا ہے وہ 1 سینٹی میٹر، اور اس کے لیے 30 جو راؤنڈ آف ڈویژنز ہیں وہ ہوں گے، اور اس کے بعد جو ہے صرف 10 راؤنڈ آف ڈویژن پہ وہ اتنا ہو جاتا ہے کہ اس کے بعد شوگر ہے. تو اس میں کتنا ایک ٹائم ڈیوریشن لگ رہا ہے یہ سارا؟
یہ دیکھیں، یہ تھیوریٹیکل ہے. سب سے پہلی بات یہ ہے کہ not all the tumor cells they divide. یہ ایک تھیوریٹیکل آپ کو ایگزامپل دی تھی. There is only one tumor جو کہ بچوں میں ہوتا ہے، برکٹس لمفوما کہلاتا ہے، جہاں پر کہ at any given time we can demonstrate that 100% of the cells are divided. Otherwise اگر آپ ایگزامپل لیں بریسٹ کینسر کی، at any given time maybe somewhere between 5 to 30% cells are cycling, rest are silent. تو اس لیے ایسا نہیں ہے کہ یہ تو ہم نے ایزیوم کیا کہ سارے سیل ڈیوائڈ ہو رہے ہیں، ٹھیک ہے نا، لیکن سارے کینسرز میں ایسا نہیں ہوتا، ٹھیک ہے نا. لیکن جو بہت ایگریسو ٹیومر ہوتی ہیں، دے میں جیسے برکٹ لمفوما ہے، دے میں ڈبل اوور نائٹ، وہ اگر جب ہم دیکھتے ہیں تو فوری طور سے ان کو کلینیشین کو فون کرتے ہیں، بھائی یہ چائلڈ ہے، اس کو برکٹ لمفوما ہے اور اس از سو ایگریسو بٹ پوٹینشیلی کیوریبل. جو جتنا زیادہ ایگریسو ٹیومر ہوتا ہے اتنا زیادہ اچھا رسپونڈ کرتا ہے کیمو تھراپی کو، کیونکہ جو کیمو تھراپیوٹک ایجنٹس ہوتے ہیں نا، دے کل دا ڈیوائڈنگ سیلز، رائٹ. تو دے آر پوٹینشیلی کیوریبل، لیکن اگر ذرا بھی ٹائم نکل گیا تو وہ آپ کو تھیوریٹیکل سمجھانے کے لیے تھا کہ کوئی کینسر کی بات ہی نہیں ہے، یہ پیسوں کی بات بھی ہے نا. میرا ایک دوست تھا، وہ واز لائک می بھی، وہ بڑا پیسے والا ہو گیا. میں نے اس سے پوچھا بھائی کیا سیکرٹ کیا ہے؟ کہنے لگا شاید یو ڈونٹ نو دیٹ یو ہیو ٹو چیز دا فرسٹ ملین اونلی، ریسٹ آف دا ملینز ول چیز یو. تو بات یہ ہے کہ یہ، لیکن اس میں بھی پھر آپ کو یہ دیکھنا ہوگا نا کہ آپ اس پیسے کو جو ملٹیپلائی کرتے ہیں تو کس طرح کرتے ہیں، ورنہ تو وہ بھی ڈبو دیں گے آپ. نہیں تو وہ تو ایک تھیوریٹیکل ایگزامپل ہے کہ یہ ایکسپونینشیل گروتھ ایسے ہوتی ہے. یہ آپ کیلکولیٹر پہ کر کے دیکھیں، آل آف اے سڈن جو ہے نا، اسی لیے تو ان نو ٹائم جو ہے یہ بیکٹیریا یہ وہ بوم، مطلب کوئی لمٹ ہی نہیں ہوتی کہ بلینس اینڈ ٹریلینس جو ہے ان نو ٹائم 30-40 دفعہ وہ ڈیوائڈ ہو تو ہو گیا. 40 دفعہ بھی اگر وہ ڈیوائڈ ہو گئے تو 1000 بلین ہو گئے.
کسی کا کینسر ڈیجنریٹ ہو رہا ہے، سر اس کا پہلا سمپٹم اس آدمی کو کیا لگے گا؟ نہیں،
وہ ہر کینسر کا ڈفرینٹ ہے. ایک ہم جب میڈیکل کالج میں تھے تو ہم سے سوال پوچھتے تھے کہ آپ کو کینسر ہونا ہے، آپ کو یہ کینسر، آپ کو کینسر، آپ ایزیوم کریں کہ کینسر آپ کو ہونا ہے، اب چوائس ہے کہ کون سا کینسر. تو اس کا جواب یہ ہوتا تھا کہ وہ کینسر جو کہ ارلی ڈیٹیکٹ ہو جائے. تو اس کا ایکچولی جواب پتہ کیا ہوتا تھا؟ لارنجیل کینسر اور ووکل کارڈ کا کینسر. کیونکہ ووکل کارڈ میں ذرا بھی کچھ، جیسے میری آواز بیٹھی ہوئی نا، ذرا سا ایڈیما ہوگا کچھ، ایک دم سے آواز چینج ہو جائے گی. اٹ ول کم ٹو دی میڈیکل اٹینشن. اور جب سرجن ENT سرجن کھول کے دیکھے گا تو اس کو نظر آئے گا یہاں تو کوئی گروتھ ہے، اس کی واپسی ہو جائے گی اور جو بھی سرجری ہوگی مطلب. تو اٹ ڈپینڈس کہ جو ہے مطلب کیا کہنا چاہیے کون سے کینسر کی بات ہو رہی ہے. ٹھیک ہے نا. بعض کینسر جیسے ہیں کچھ میں تو اسکریننگ آپ کو دیکھیں نا، جو ایسے کینسر ہیں اسکریننگ از ہیلپ فل کہ ارلی اسٹیج پہ ڈیٹیکٹ کر لیں آپ. یا پھر اب جیسے اوویرین کینسر ہے، بڑا کامن کینسر ہے. یہ کوئی عام طور سے سمٹم نہیں ہوتی، صرف اسٹمک تھوڑا سا اپسیٹ ہے. پھر شاید کوئی بہت عرصے بعد کوئی ملے تو کہے گا کہ بھائی آپ کی کچھ ٹمی باہر آ رہی ہے، خیریت تو ہے. پھر کوئی کہے گا یار الٹرا ساؤنڈ کرا لو کچھ. وہ الٹرا ساؤنڈ میں پتہ چلے گا کہ یہ تو اوویرین سسٹ ہے. پھر وہ گائنیکالوجسٹ اس کو آپریٹ کرے گا اور پھر آپ اس کی آپ کی بایولوجیکل لک اور بیڈ لک کہ وہ ٹرن آؤٹ ٹو بی میلیگننٹ اور بینائن. تو کینسر از ناٹ ون ڈیزیز. ٹھیک ہے نا. جنرلی تو یہی ہوتا ہے، لیکن اتنا اوور لیپ ہوتا ہے نا. اب جیسے اس میں ہوتا ہے گیس ہے وہ 7 اپ منگا کے پی رہے ہیں، یہ کر رہے ہیں، بعد کو پتہ چلتا ہے کہ وہ تو ہارٹ اٹیک ہو رہا ہے. ٹھیک ہے نا. تو اسی طرح سے اس میں بھی ٹھیک ہے. کوئی ایسی چھپی ہوئی چیز ہے تو عام طور سے آپ کا ویٹ لاس ہو رہا ہے مطلب وداؤٹ اینی ایکسپلینیشن. دیٹ ول بی دی اونلی سمپٹم. جیسے پینکریاٹک کینسر ہے، جن میں بھی تو سوائے اس کے کہ آپ فیل کر رہے ہیں کہ آپ کا ویسے تو ہیبٹس ہو رہی ہیں لیکن آپ کا ویٹ لاس ہو رہا ہے، تو کوئی دیر از نو ون آنسر.
میری امی کو تھا ان کی گال بلیڈر میں اسٹون تھے. پھر سر جیسے ان کا گال بلیڈر ریموو ہوا، مطلب کتنے میں پتلی گئی ریموو ہوا تو سر پھر ان کو کینسر ڈائگنوز ہوا اور پھر ان کی کیمو ہوئی 6 منتھ تک اور پھر سر ان کی ڈیتھ ہوئی. تو سر
گال بلیڈر کا کینسر ڈائگنوز ہوا. گال بلیڈر میں دیکھیے بہت ان کامن ہے، لیکن گال بلیڈر جو ہے وہ اسٹون چونکہ بہت کامن ہے تو وہ ہمارے پاس اسی لیے آتے ہیں یہ دیکھنے کے لیے کہ وہ تو سب کو پتا، سرجن کو بھی پتا ہوتا ہے کہ اس میں کرونک انفلیمیشن ہے اسٹون کی وجہ سے اور اسٹون تو نظر آ رہے ہوتے ہیں. لیکن ہمارے پاس اسی لیے آتا ہے کہ مے بی ان اباؤٹ 1% آف دی کیس اس کی ایسوسیشن گال بلیڈر کے کینسر کے ساتھ بھی ہو سکتی ہے. تو یہ بس جیسے میں نے کہا یہ ہم کل بات کریں گے جو بایولوجیکل لک اور بیڈ لک ہے، اور کچھ کینسرز ہیں جو کہ پریونٹیبل ہیں اور کچھ ہیں زیادہ تر نان پریونٹیبل ہیں، لیکن ان کے لیے اب کچھ چیزیں ایسی ڈیولپ ہو رہی ہیں جیسے کہ پیپ اسمیئر تھا یا HPV وہ ہے، ویکسینیشن ہے، یا وہاں پر اس کے لیے کولون کے لیے بھی ہوتا ہے جیسے آکلڈ بلڈ. وہ گھر پہ آپ کے وہ بھیج دیتے ہیں بوٹل کہ اسٹول ٹیسٹنگ کے لیے آکلڈ بلڈ، کیونکہ سب سے پہلی چیز جو اپیئر ہوتی ہے اگر لارج باؤل کا کینسر ہو تو وہ بلڈ جو کہ صرف مطلب آپ کو ویسے تو پتہ نہیں چلے گا، وہ بھی ایک اسکریننگ ٹیسٹ اس کے لیے ہے جو کہ یوز ہوتا ہے. یا پھر کولونوسکوپی کرتے ہیں کہ کوئی زیادہ اگر ہائی رسک ہو دیکھنے کے لیے کہ کوئی پالیپ ایسی چیز تو نہیں ہے. جو لنگ کینسر کے لیے جو زیادہ ہائی رسک ہوتے ہیں اسموکر، ان کے لیے اب ہائی سینسٹیوٹی جو ہے وہ CT اسکین جو ہے ریکمینڈ کرتے ہیں کہ بھائی آپ. تو اس قسم کی چیزیں ہیں، لیکن کوئی ایک سمپل آنسر نہیں ہے، مطلب اٹ ہٹس ایوری ون ان اے ڈفرنٹ وے. ٹھیک ہے. اچھا
تھینک یو سو مچ.
سب ہو گیا. چلیے اب کل انشاءاللہ سیکنڈ پارٹ میں